Okay, good afternoon, everybody. So my name's Arjun Takhar. There are lots of familiar faces there in the crowd. I'm one of the other surgeons at Southampton, along with Tom Armstrong, and we've sort of taken on Neil's mantle of doing the majority of the neuroendocrine work at Southampton. This is well, there aren't that many youngish people in the crowd, but when I told my trainees that I was going to do like a little bit of a "this is your life" type thing with Neil, the younger people had no idea what I was talking about. But the truth is, we've been meaning to do this for a long time. Ever since Neil stopped operating, there has been a thing in the back of my mind, which I have talked to Joe about a number of times, to really have a conversation with Neil about his philosophy, how he got into being a surgeon. Neil's had a lot of trainees come through, and we are sort of, I guess, carrying the torch for what he taught us, and we still use quite a lot of the principles that he really ingrained into us when we worked with him. And actually, from our side, I thought it was quite important that we, have a proper conversation with Neil about that, but also that this would be really quite informative and helpful to all the patients that he's treated in the past, because obviously he's quite limited now, but actually his mind is still as active as ever, and he is still pushing us in all sorts of slightly uncomfortable ways at times to hit new ground, break barriers in cancer treatment. So we thought that this was a good opportunity where we could hopefully record this. It'll be on the charity website. And actually, that was me saying no swearing and no scatological references. And those of you who've been to the ball might remember that, et cetera, et cetera. But as you know, Neil may not conform to that, which has been his general want. So what we're going to do is, I'm going to shout my questions, and then hopefully Neil will be on the microphone, and you can hear. But we're going to sort of do a little bit of a run through Neil's career, why he got into medicine, why he got into surgery, why specifically neuroendocrine tumors, etc. I'll give you a bit of background how I came into Neil's orbit. I did all my training in the West Midlands. The unit there is one of the biggest in the country, still one of the biggest in the country, and I did my training in liver transplantation and operating on the liver and pancreas. And in our line of work, not only do you have to do research, so get a PhD, etc., to make yourself competitive to get a consultant job, but you've also got to have additional skills that you need to make yourself attractive to people who might give you a consultant job. And I had a plan that I wanted to do keyhole liver surgery, and had set up a fellowship in Brisbane with a chap called Neil O'Rourke to do that just as I was about to become a consultant. That fellowship fell through, mainly due to funding issues. They were dragging their feet a little bit, so I rang them up and they said, well, actually, we've just worked out that we don't really have any salary to pay you, and you can come along and be a free fellow, but actually, you won't get paid. And obviously that wasn't particularly attractive to me or my wife, I have to say. And I spoke to one of my consultants in Birmingham and said, this has fallen through, and I'm really sort of struggling to find a place where I can go and do laparoscopic, so keyhole liver work. And he said, well, actually, I know a guy, I don't know, I've always thought it a bit strange that you were going to Brisbane, because there's a chap in Southampton who's been doing this for a long time, and why don't you go and work for him? So this gentleman who gave me this advice, you may or may not have heard of him, was the man who wrote his name onto a liver and then got suspended for it in Birmingham. Okay. You won't be surprised to know that he's quite a good friend of Neil's, or has been quite a good friend of Neil's.
I've played noughts and crosses on the liver with him. Not really.
No. But in fact, the really good thing that Simon did was that he got on the phone as we were speaking and rang up Neil and said, I've got a young trainee who is very keen to do laparoscopic liver work. He's had a fellowship that's fallen through. would you think about potentially giving him a year? So generally fellowships tend to be a year-long job in Southampton. And one of the really positive aspects about Neil is that Neil, I'm sure you know this, or sort of those of you who've been treated by Neil, and you could potentially accuse Neil of being a tad too optimistic at times, but Neil never says no. So Neil literally said, yeah, why don't you send him down to have a chat to me? I don't know whether we have funding yet, but let's have a conversation and see whether we can make it happen. So I caught a train, came down and did Neil's course, which was the laparoscopic course that Neil and Moabi Halal ran, and we got on like a house on fire. And he said to me, we don't have the funding right now, but we're going to try and make funding for you to come in a few months' time. And that's how in the end December 2011, January 2012, I started working as a senior fellow at Southampton. And it's November 2024, and I'm still here, and I've been a consultant now for 10 years. So that's how it started for me. And all along that time, Neil was a mentor to myself, to Tom, and to a lot of other people who've gone on and become consultants. And I have to say, one of the reasons we do neuroendocrine tumors, but also our philosophy of how we operate and treat patients, really is derived from those times that we have spent with Neil. And for me, it was particularly good because Neil was a mentor. I'd just become a consultant in Southampton, but he was a really good sounding board. And as new consultants, that's really, really quite important, that although we're expected to be able to technically perform all these operations, which we can, the really difficult bits about being a consultant is the actual decision making. And in fact, frequently we tell our trainees, it's easy to operate, it's quite difficult to work out when not to operate, when to do other things. And actually those were the bits that Neil has been invaluable for myself, and I'm pretty sure I'm talking about my other colleagues, in helping us think differently. So that's how I came along. And actually Tom was not similar, but Tom has been a trainee of Neil's for a long time, and we're still using those principles in how we operate. So I think it'll be really, really good when we ask these questions, and Neil, without being controversial, will give us some answers. So I'm going to start off, my first question, Neil, is going to be along the lines of, why did you choose medicine, and how did you end up in Southampton?
Okay, well, thank you for that. Thank you for the little intro. Before I answer that question, I just point out that Simon Bramall, the surgeon from Birmingham, also pointed out that Arjun was the best trainee he'd had for years. And we'd already pointed the best trainee we'd had in Wessex in the previous decade. So we already had Tom. And I knew that we needed another pair of hands. I'd already been diagnosed with MS. And I knew the writing was on the wall, and I wanted somebody good. So right from that first phone call, I was thinking, well, if he's that good, let's see what he's like, because I want us to keep pushing with the unit. Anyway, back to the question. So why did I want to do medicine? Well, when I was about 15, 16, doing my O-levels, I wanted to be a war correspondent or a journalist or something like that. My father was a scientist, a chemical engineer, and I was a good all-rounder, not like unbelievably brilliant at any subject. But I could have done the arts, I could have done the sciences. My father wanted me to do the sciences, so for my A-levels, I did maths, further maths, chemistry and physics. It didn't take me that long at A-level to work out I was never going to be brilliant at all of this stuff. It was too dry for me. I was not going to be a lab person. I needed more human contact. So I looked again at what could I do with these sciences. And the obvious thing, if you like talking and communicating with people, and I always like helping, was medicine. So I started to buff up my CV to get into medical school. Was a bit of a struggle. I got 5 rejections on my application form, which was one of those less lucky breaks. And that was because my head of sixth form had done the reports before the results of the mocks were in, because he was leaving. So I had very poor projected grades, which wasn't a reflection of how I did in the mocks. Anyway, that's just the way of these things. So my new head of sixth form was a graduate of Southampton, and Southampton had been my first choice for medical school. So he contacted their admissions office and said, actually, we've got some unusual circumstances. We've got a very deserving guy. Would you think again? There was a real error in his in the assessment from the school. So I went down, had an interview in Southampton informally, and they said, well, we've given all our places away for this year, but we will put you on the reserve list, but you'd have to come in through clearing. So I got into medical school through clearing, which in those days was reasonably unheard of, because the places were always so oversubscribed. Anyway, that's how I got into medicine, really.
And why did you end up choosing surgery?
So I've always been an enthusiast, and once I was actually doing all the clinical specialties as a student, I pretty much loved everything. And it was really difficult to think, what are we going to do next? But in Southampton, in our third year, you had to pick something to do in more depth and do a research project in the fourth year. And I had been inspired by a guy called Chris Smart, who was a urology surgeon. He was full of stories, great with his patients. Everybody loved him. Staff loved him. Patients loved him. He was great in theatre. He would chop out ridiculous things. And I thought, actually, I might quite fancy being like that. So Chris Smart was my initial kind of role model that made me think perhaps I want a bit of surgery, because, to be honest, the first few years I thought, I'll be a GP. But there was something about surgery that appealed to me, and so I did a fourth-year project, which took up about half of my fourth year doing some research, and I worked for some less inspiring surgeons, shall we say. That's probably the next bit I'll gloss over. But I got some really lucky breaks with my research. I worked hard at it, and I got a series of presentations, publications. I got a first author publication in the British Journal of Surgery as a medical student. So that normally doesn't happen. And so there was a huge element of luck behind that. But you've got to be in it to win it, and got to make the most of your breaks. So so I was off to a flying start, really. I then did my house jobs after I qualified. My surgical house job was in Southampton, and working for some of those less brilliant surgeons, shall we say. And I was working at the old Royal Southampton Hospital, so a smaller hospital. And I was on a 1-in-2 rota. It was the last 1-in-2 in Wessex. A 1-in-2 means every other night, every other weekend, plus 9 to 5 or 8 till 6. So they used to call it units of medical time, UMTs. So I got 10 UMTs for my routine hours, and then I got 17 UMTs for my additional hours. So it was 108 hours a week as a contract. Some of those hours you did fall asleep, sometimes on your feet. There was other stuff that went on as well, some of it.
Which we can't talk about.
Again, we can't talk about the old doctor in the house stuff. Who were matron. So it was, they were entertaining days, but at the end of my surgical house job, it was a prestigious one, I was absolutely just destroyed. So I didn't even apply for any jobs at the end of that. I just came to the end of my 6-month surgery, and I just had to reevaluate. I went away on holiday to the Bahamas with one of the nursing sisters, and reevaluated life. And it took the first week I was still inhuman. The second week I decided, okay, yeah, well, I'm really don't know what I want to do. I ought to just get an A&E job. So I came back and looked in the British Medical Journal and looked for any A&E jobs that weren't too far away, and started pretty much immediately. So I got a job in Swindon, and Swindon Princess Margaret Hospital. It was quite a nice hospital to work in, but it was not a great department. In those days, A&E was not a proper specialty in a lot of places. So I didn't realise till I actually started that as a senior house officer in accident and emergency, I didn't have a registrar above me, or a senior registrar, or indeed a consultant. There were some GPs that would pop in and do a few sessions, and if there was something you didn't know about, then you just had to refer to the main hospital teams. So that was another trial by fire, and it was a fantastic experience, because you really had to become very dependent and learn very quickly, and become a specialist in all kinds of things that you knew very, very little about. Bit of medical student book knowledge. But one of the other things that happens in A&E, if you don't have tons of supervision, is you get to do an awful lot of stuff, a lot of practical interventional procedures. As I went through about my third month of A&E, I thought, well, actually, what do I really enjoy? I really enjoy doing things. I like doing practical stuff. I like sticking pipes into chests, or sewing people up, or pulling bits of glass out of your eye or something. I like doing things, the practical stuff. So I thought, okay, I'd said I was going to do surgery before. I didn't know, but now this has reaffirmed that that's the right course for me. So I set about doing my primary Royal College of Surgeons exams, primary FRCS, which was quite a nasty exam in those days. It's less than 1 in 5 pass rate. I sat that about 6 months later. I took some time out to do locums and just have a bit more time to do some book work, because it's really hard to do book work if you're doing the job like I was in Swindon A&E. That's another great, the hours then, you did a 4-week rolling rota. So you did 1 week where you came in at 8 a.m. and left at 8 p.m. So that's 7 days of that. Then you did, straight after that, you did 7 days of midday till midnight. Then you followed that on with 7 days of 9 p.m. till 9 a.m. and then you got 6 days off. And then you did it all over again. And those 6 days off, that was your holiday as well. So because there were only 4 of you, so nobody could go sick, nobody could take holiday. So I tell you, these youngsters, they don't know they're born. But they don't believe you if you tell them. Anyway, so it would have been hard to pass any exams working any of those rotas. So I took some time out, did some locums, pretty much anything, and I sat my exams. It was good I had some time out as well because my father got diagnosed with a really aggressive malignancy, he had about 6 weeks from first seeing the doctor till he passed away, I knew right from the start that it was awful. Just everything about it was terrible, and he died in between the 2 parts of my surgical exams. So they were about 10 days apart, and that was character building. I think it's safe to say, but before he died, I told him my past, which was a lie. But I wanted him to go out with some good news, and anyway, I was I was really surprised at the past, and I'm eternally grateful to Matt Hayes, who was in my year at medical school, and he put me up for those days around the exams, and he ended up as a colleague in Southampton, and I operated on all kinds of stuff because he took over from Chris Smart. Chris Smart had inspired him to do surgery, just like he inspired me to do surgery. And we all need role models. We all need people who give you inspiration, and so that's kind of how I got a bit further down the surgical pathway. Do you want some more?
So I guess the next question is, why did you choose liver and pancreatic surgery?
Well, again, everything I did, I enjoyed. So my first surgical rotation job was down in Plymouth, and I did trauma and orthopedics, I did some thoracics, I did neurosurgery. I don't want to hear about my neurosurgery, but it will be in the book. And I did urology, I did breast surgery, I did vascular surgery. Didn't do any liver surgery or pancreatic surgery because there was nobody in Plymouth doing it, even though it's one of the biggest hospitals in the country. Or maybe somebody would occasionally dabble with pancreas. Then I managed somehow to get onto the surgical rotation in Southampton. That was around Wessex. That was by luck as well. It's another lengthy story, but I became a specialist registrar in surgery without ever having an interview or even applying for the job. And that was an accident when I was doing a locum in Swindon. It was a long-term locum, and they brought in the new career grade of specialist registrar, and somebody somewhere in admin, when they were asked in the HR office, who are your registrars? And I said, there's Mr. Pearce. And so one day I just got a big brown envelope and it had my national training number in. And I was WS023 Specialist Registrar in Surgery in Wessex. So I spoke to my boss and he said, well, you're good. You're really good. Just take the breaks,
Yeah.
Don't tell anyone, I won't. So miraculously, I've become a surgical registrar without applying, and that was a general surgery rotation. And I had my first encounter with a liver surgeon there, a guy that I subsequently worked with, Professor Primrose, and he met me at my regional in-training assessment, and I thought I'd been doing pretty well. And his opening line was, Mr. Pearce, Your logbook reads like a catalogue of surgical nightmares. He said, he followed that up with, I don't know who appointed you, but I never would have. Unfortunately, he never really checked who had appointed me. But again, I was working in Swindon at that time, and that was my first year on the rotation. And I worked for a lot of bosses who didn't like to come in very much. They'd done a lot of hours in their training, and now they were enjoying life, in their 50s and 60s. Bit of golf, maybe when they're on call, go out on the yacht, or I even phoned one of my consultants up. And he said, am I on call, Neil? He said, oh, hang on, big fence coming. And in the background, riding to hounds whilst he was on call. So there was plenty of opportunity for surgical learning again, because it used to get left just to do a lot of stuff. So I would take a textbook with me when I was on call, and I would, in surgery we used to have a saying, see one, do one, teach one, which was you'd see an operation, then you'd do it, and then you'd teach it to somebody. That was kind of our rapid learning process. And it did sort the wheat from the chaff, and a lot of people couldn't cope with it. But I'd got a book, Farquharson's Textbook of Operative Surgery, which I pinched from the library and just kept with me continuously. And so I did a lot of operations that I'd never seen, and sometimes never heard of. And I just read them up and just did them. And that was how surgical training was in 1995. So I had a lot of years as a registrar, and I did some research, which was with a pancreatic surgeon. Had to do 2 years of research, and it was pretty miserable because I was rubbish at research. And I was looking at the movements of the gallbladder and stuff like that. I somehow got a thesis out of it, but I also got labelled as like a pancreatic and maybe liver trainee, because I'd worked with this guy's team. And so at some point I had to go and do some. So they sent me to Basingstoke in 99, 2000, and I worked for a guy called Merv Rees and another called Tim John, who were liver and, to a much lesser extent, pancreatic surgeons. And Merv Rees was the most famous liver surgeon in the country, probably at that stage. He had revolutionised the approach to secondary liver cancer in the from the bowel, so bowel cancer spread to the liver, and he had made liver surgery safe. There had been one of the surgeons I'd worked for at the Royal Southampton my first year, qualified, used to operate on the liver. The patients, you didn't really have high hopes for them getting out of hospital. But Merv Rees, he had done, at that stage about 300 or 400 liver resections over a decade, and his mortality rate was about 2%. So that was completely different from what everybody else was doing, and he was really advancing the cause of modern liver surgery. And I went there and thinking, well, I've done a lot of surgery in a lot of places. Let's see what happens. I know he's got a tough reputation, but he did grind me into the dust for about 6 months. It gave me very little to do, and just made you. I was on the verge of quitting surgery, to be honest. But then something changed. I don't know why. And I started to get more to do, and I think he'd wanted to recreate me in his own model, I think that was his approach. And if he discovered that he couldn't quite break you, then you were tough enough for him to refashion. So after 6 months of humiliation, I got 6 months of really intensive, high quality training, and it reminded me a lot of something my father always used to say to me, which was, "There's always room for improvement," and that's something that I've put up on a slide many, many times at presentations, and there's always room for improvement. And he also gave me another line which I've kind of worked with, which was just because it's difficult doesn't mean you can't do it. And so I started to appreciate that the bar could always be higher, and I really like the challenge of liver surgery because I like being in a theatre doing something technically extremely difficult, knowing that the other surgeons in the hospital couldn't do it, and they were getting worse results for doing easier surgery than we were getting for doing, the kind of Cadillac of surgery. So then after that, I went and had a year in Southampton, and we had a liver surgeon there who was not as well established as Merv, but he was starting to push things in the right direction. But unlike Merv in Basingstoke, where he was a big fish in a small pond, Southampton has got neurosurgeons and cardiac surgeons and every kind of complex surgery available. So if you're trying to build a new unit and develop liver surgery, there was not a lot of money or whatever put into it. There was a pancreatic surgeon that I'd done some research for, and his results were much more in keeping with those that had been published in a paper in the mid-90s about pancreatic surgery, where they'd reviewed what went on around the country. And the mortality rate was around about 1 in 4. So basically 1 person in 4 having planned routine pancreatic surgery went home in a box because the surgery wasn't done well, the patients weren't selected well, they weren't managed well afterwards. When things went wrong, they went very wrong. And there wasn't really established training in it. So I was definitely working in an underperforming unit. But I did find that I could bring some of the stuff from Basingstoke and actually start to make some changes. So I got on well with the liver surgical guy. I got on really well with him. And I thought I needed to go and do a fellowship somewhere, finishing school, a bit like Arjun came down to finishing school with us. And I was also looking at Brisbane and Nick O'Rourke and Australia and various options. But again, I decided to stay in the UK, and I went to Leeds. And I worked for one guy there in particular called Pete Lodge, and he's still doing liver surgery, as is Merv. And he was phenomenally inspirational again. And he just didn't understand the meaning of no, or you can't do it. He did some really radical things that nobody else, pretty much anywhere in the world, was doing. So he was in particular doing something called ex vivo liver resection, where, a bit like doing a liver transplant, when you take a liver out from a dead or nearly dead person to put in somebody else, you've got to cool it down to transport it, fill it full of solution to keep it alive for a few hours. Then you've got to plumb it back in. So he would, for patients with secondary bowel cancer in the liver, in some of the most awkward places, he would take their liver out, cool it down, chop it up on the bench next to the patient, take all the pieces out, and then plumb it back in again. So that was quite feisty surgery, I think it's safe to say. And again, a bit like Murphy, showed me just a whole different way of approaching tumours, and just thinking about different anatomical approaches and different ways of making something that is conventionally inoperable operable. Now, the X50 liver surgery hasn't really taken off, partly because it's too challenging and it is high risk. And although he had a few stunning results, there were a lot of patients who got recurrence and didn't do well at the end of the day. But again, that pushed me towards really looking at what you could do with liver surgery, and I did more pancreatic surgery there as well. And I again looked at ways of doing the pancreatic surgery that could be done so badly, so much better. And I saw different ways, a higher level. And I thought, well, that's doable. But I went, I was in two minds at that point, where to go next. The guys in Leeds were saying, well, why don't you stay here as a senior fellow, and we'll look and see if we can find a job for you, as a consultant over the next year. And my old colleague, Professor Primrose, the one who'd said, I don't know who appointed you, but I never would have. He said, Neil, get yourself back here. I'll have you in a job by Christmas. But a little bit like my house building, he didn't specify which Christmas. So I came back in 2002 in October and started again initially as a senior fellow. Then the pancreatic surgeon had a few problems with his back. I was encouraged to go on leave for quite a long time. He had some surgery and so on. And I did his locum, and although I didn't really want to do pancreatic surgery, I made myself, they couldn't get rid of me because I could produce much better results. The patients all went home. My first 50 patients, I didn't have an in-hospital death. I basically showed that you could do things differently because I had been properly trained, and there were a lot of other improvements. It wasn't just about me, but it was improved teamwork and better case selection, better discussions in the multidisciplinary team, better involvement with the anaesthetist. So we weren't just getting patients last minute admitted from clinic, newly diagnosed, have operation tomorrow. We actually worked people up properly, and we avoided a lot of disasters. So it got to Christmas 2003 and there was still no post. So I had a chat with Prof Primrose, and I worked out that if I wanted a job, I was going to have to write the business case for it, and then I was going to have to write the advert for it, the personal spec, and so that's what I did, really. I basically created my own job, and I can tell you that the advert was a bit unusual because it specified that the successful applicant must be able to do laparoscopic liver surgery. And at that point, there were only 3 surgeons in the UK who were doing any, and I was one of them. So the other 2 were established consultants and wouldn't be interested in moving to Southampton. But it was quite a competitive interview process. So the pancreatic surgeon didn't particularly want me to be appointed. And so he invited various people to apply. I had John Fawcett, a professor from Australia. He, really established leading liver surgeon. His wife was from somewhere in Hampshire and wanted to go back to the UK. So he applied, and I had all these, very good people. But fortunately, John Primrose kind of warned them off. And so, yeah, anyway, I got through that, and the rest is history. And I was a consultant, so I had 10 years practicing. Got diagnosed with MS in 2011, so that was a bit like a bereavement, knowing I was going to lose my surgical practice. It was my legs that were affected to start with, but by towards the end of 2013, my hands were getting heavy at the end of operations, and I was looking right from 2011 to make sure I had a successor, and Tom was working with us, and it was obvious that he was the kind of quality that we needed, and he would be able to take things on again to the next level. And so brought him in, split my practice with him, and then handed the rest of it over to Arjun. Yeah.
So why neuroendocrine tumours, Neil?
Do you want another long answer? So neuroendocrine. I encountered a few neuroendocrine tumours in my training. So the guy, Merv in Basingstoke, said, "I don't need to operate on them. Really slow, don't do anything. There's the odd one where we take something out of the liver, but in general, we just leave them, and they get followed up by the physicians." And the guy up in Leeds, they used to send them down to London for PRRT, but they weren't really interested. There would just be the occasional one they'd operate on, something particularly easy. Because they said, they're good prognosis tumours, and there's other treatments, and they get watched by somebody else. And I found that there was this very kind of too relaxed approach. What bothered me was, if they're good prognosis tumours, rather than trying less hard, shouldn't we try harder? Because you've got more to gain. And then if they are going to do better, certainly you should be offering them all the stuff that you're offering to the your standard, like bowel cancer secondary patients. And this time I was mainly focused on the liver. And there was a lady called Val Lewington, who was one of the pioneers of PRRT. And she'd been starting PRRT in Southampton. So I'd met her as a registrar, and we'd talked about cases, and then when I was there as a locum, she gave me a couple of challenging cases to look at, and I said, well, this one, if looking back at the scans, I could have done at any point in the preceding 5 years, but now it's too difficult. And I said, if only we'd chopped it out 5 years ago, the patient would be there with clear scans, because they didn't have secondaries in the liver, just had a big bulky thing in the pancreas. And then there was another one with a relatively small thing in the pancreas and a bit of disease in the liver. I said, well, the pancreas is easy, the liver's easy, why don't we do it? And so I started with a bit of slightly out-of-the-box thinking. They were relatively straightforward, some of those. And then, although she moved away, she encouraged patients still to come to my direction for a second opinion. And so I started to get some horribly difficult second opinions coming my way. And bit by bit, I became more and more persuaded that the right thing to do was to offer patients with good prognosis disease, but bad patterns of disease, really aggressive surgery. Aggressive doesn't mean I shouted at them or the tumour. It meant that I absolutely wanted to push the boundaries. And so I did the same with a few other tumour types, gastrointestinal stromal tumours, gysts. They were, I've got some great pictures of some whoppers that I chopped out. That was around about the time that there was a new drug coming out for those called Gleevec, which suddenly miraculously shrank them. So that spoiled my fun. But the neuroendocrine became a growth industry, and I just found more and more, and I started giving a few talks here and there, initially just around the region. We had there'd been something called a Wessex carcinoid meeting. So that was a group that met 4 times a year in an evening, usually at the Chilworth Hilton, and over a couple of glasses of wine, a few old duffers would stick some scans up and say, "Oh, it looks bloody terrible. Nothing we can do about that." But every now and then I would get a bit of trade, and I would pipe up and say, "Well, I think we can." And so bit by bit, my referral base increased, and I started to think that we actually needed an MDT in Southampton, which I think was quite a key move. And so we started that initially once a month on a lunchtime on Wednesdays. And initially it was just Brian Steadman, David Breen, can't think who else, but not a lot of people. That was the start of really developing our presence. And if you've got an MDT and you're calling it a regional MDT, even if there's no funding for it, people start to think that they need to refer the cases in. And so we started to get more and more cases referred, and lots of work. Was that short enough?
Yeah, that's pretty good. So from those humble beginnings, we now have one of the biggest neuroendocrine MDTs in the country. We continue to remain one of the better second opinion centres. We get people from all across the country wanting a second opinion with us if they're not quite happy with what they've been told in their own local centre. And our practice, because we do it as a combination, so you saw Dr. Chan gave you a talk, and he works at the QA. We have a true regional approach, which is again quite unique in terms of subspecialist teams. So we've got people. We run clinics in Bournemouth. We have a central meeting in Southampton, and we run clinics at the QA. And that model is relatively unique in the UK. And outside of the Royal Free, which probably still remains the mothership of neuroendocrine disease in the UK, we're probably one of the biggest centres, and we're certainly the biggest surgical centres. So it's quite unusual for neuroendocrine MDTs to have surgeons that lead it. So Tom Armstrong's our lead, but Neil was our lead to sort of begin with. And when Tom's not there, then I lead it. And most neuroendocrine MDTs in the country are led by either a gastroenterologist or an oncologist. And hence, we still continue to think really differently in terms of our approach to neuroendocrine disease. And, it's pretty much entirely due to the fact that Neil started it that way, and we are obviously continuing it that way. So how do you spend your time now? Because you're like an advocate, aren't you, with planets and You want to increase the research profile and all sorts of other things. So could you tell us a bit about that?
Yeah, I mean, so we set up Planets in 2011, shortly before I was diagnosed with MS, and it wasn't put in place as a substitute for surgery, but it has been, one of the saving graces of my my MS diagnosis, that it's enabled me to feel useful and still contribute and have interaction with patients, and whether old or new, and contact with the team and involvement, and it's enabled me to carry on with that thing that I got from my dad at my my exams. There's always room for improvement. Doesn't matter how many A's you've got on your school report card. There's always room for improvement somewhere. And we are unbelievably blessed with our current neuroendocrine team. When the ENETS people come round to do their assessment, when we first did our application, they said it was the best application they'd ever had to be a centre of excellence. And the reviewers, when they came around last time, said it was the best review they'd ever done. So we are really trying to be a European and indeed worldwide centre of excellence, because we've got all of the specialties really heavily involved. We've got our patients heavily involved as well, offering support groups, and all of the many other things that we do is really unusual. Our research profile's going up, and having the ability now that we've got enough turnover to be able to fund more research projects. So people like MRA hear of us and spontaneously come to us and say, is there any chance that you could help with this? It gives us the ability to do what we really want to do, which is kind of hit all of our aims. Our charitable aims are firstly to support patients, and we've got a range of cancers that we do that for, not just NET. But then we also want to support innovation. So we put a lot of money into innovative treatments. It's not so useful for neuroendocrine, but our intraoperative radiotherapy machine delivers the equivalent of a full course of radiotherapy in 5 to 10 minutes. And we're doing that for pancreatic cancer patients with borderline disease. So it's, having been able to put £1 million into that and get a discount machine, first in the UK, nowadays probably costs £2.5 million to buy it. That's been great. But then research is our third thing. And over the years, we've funded various MS, MD, PhD students, researchers. They're not students, they're proper qualified people. And put money into all sorts of projects, but small and large. But being involved with something like MRA's work, I think takes it to another level. And it's all about punching above our weight, always trying to be on the move, do something that makes a bigger difference, and from whichever angle that may be. I keep thinking we need to add a fourth charitable aim, because we do a load of campaigning, and we have make a lot of fuss about Creon, pancreatic enzyme supplements for those of you who need them, and also travel insurance and anything else that we can make a fuss about, we do. We want to make a difference. That's what Planets is about. We're trying to put the icing on the cake and we want all of you lot to have the best, the best outcomes from every perspective, and future generations we want to develop. We want our teams to develop, so that people aren't feeling that they're in isolation, whether as a patient or a supporter, caregiver, provider, or as a clinician, or as a scientist, a researcher. We want you all to feel that you're all part of a team. We've got common goals. We're doing stuff together, all from our different angles, directions, perspectives, experiences, skills, but we're all in it together, and we all want ultimately the same thing.
I'm conscious of time, Joe, so we can potentially take one question from the crowd, if anyone has.
I'm
for
not
Neil.
conscious of time.
Okay. Do we have any? No, we're pretty much at the end, aren't we?
If you've got another question.
So could you tell us one of your best moments in surgery?
Best moments in surgery. Yeah, unfortunately, there's just been so many. Difficult. I mean, I had some amazing moments with keyhole liver surgery. That picture behind was taken in Trinidad, and that was from the first liver surgical procedure I did in Trinidad. Just as, because I had plenty of spare time, I thought when I bumped into a guy at a conference after I'd shown a video on liver surgery, laparoscopic liver surgery, he came up to me and said, "Dr. Pearce, that's absolutely amazing, that video you showed. I'm working in Trinidad. It would be fantastic if you could come to Trinidad and help us set up the same." So I didn't say no. So I went out 14 times, and some of my other colleagues went out, and they've now got a thriving liver and pancreatic cancer center in the Caribbean. That actually is another little legacy moment. That was the first case we did, and we did a laparoscopic right hemihepatectomy, taking out the right side of the liver as a completely keyhole operation. And at that stage when we did it, there had been fewer than 100 reported in the entire world, of which I'd done about 25. So that was quite a big moment, going out there, doing that as our first case. The operating theatre got quite crowded at one point, and my colleague Celeste said, "Neil, there's somebody I'd like to introduce you to." And I said, "Well, I'm about to staple the right hepatic vein, Celeste. It's not ideal." They said, "No, I'd really like you to meet him." I said, "This is Dr. Bujidara, he's the Minister of Health for Trinidad." So I said I wanted to keep it low profile, so he invited the Minister of Health for Trinidad along to see what we were up to. That was crazy. But I've had some real big wins. Some of it's been emergency surgery, things that you just I had a patient with cirrhosis, bleeding to death from varices, and this was just before my interview for the job, and one of the hepatologists came along and said, "This guy, we haven't got anything we can do for him." So I operated on him, and that was absolute blind dog's chance. And I did an esophageal transection with, I devascularized his lesser curve, and it still wasn't stopped, so I did a splenorenal shunt. And I'd never done any of those 3 operations before, but I still had that book. What's his name? Christopher Phoebe. Yeah, he lived for about another 5 years. I'd see him wandering around the clinic on his way, to hepatology. So yeah, that's sometimes those big unexpected things. There's another patient that some of you may have met, Susan Rostron. She doesn't mind. She's been in the papers and everything, and she donated. She'd been told she had an inoperable, incurable pancreatic neuroendocrine tumor invading into pretty much everything, and so she was trying to donate her body to medical science after she died, and somehow, because we had set up a tumour bank, partly funded by Planets, she came through to my desk, and I said, well, that sounds all terrible, but I said, let's just have a look at your scans. So I got her scans, which had been reviewed in umpteen other hospitals, and I thought, well, maybe if she was up for it, then what you could do is mobilize everything from the left, every organ in the abdomen from the left, mobilize every organ in the abdomen from the right. Then, although there was no problem with the head of a pancreas, if you took out the head of a pancreas and the duodenum and the lower bile duct, even though they're perfectly healthy, and that's a massive operation, then you might have access to all the blood vessels at a point where they're not involved with tumour. And then if I took out the rest of a pancreas and took out the whole of her stomach and the bottom of her esophagus, and then if we took the tumour that was growing up into her liver out of her portal vein, and then put the ends back together, she might do all right. And she has done all right, because I did that the week after I was diagnosed with MS, and she's still alive today. So she's 13 years.
We do have to finish. So we do need to finish now. But so I'd like to. Neil's given us really an amazing story about how his career developed and how he got to this point. I think it would be sort of remiss to say that he's been one of the most inspirational people that I have worked with, and I think I would say the same that patients who've known him say exactly the same thing about him, and actually that inspiration is still ongoing, because when you speak to him, when he gives talks, he still wants to improve. He wants research. He wants cancer patients to do well. So I think all that's left for us to do is, as a colleague and as patients, is to say thank you. Thank you, Neil.
Thank you.